Thank you so much. Okay, so first we just want to take a minute and do some centering while we're having technical issues and there's so many other things going on in the world today. We just want to take just a minute to ground ourselves and just think about one thing that you're grateful for today. And you can share it and put it in the chat if you'd like to, or you can keep it to yourself. But just take a moment to think about that. Gratitude is always an important thing to remember as we move forward, and we have days like today. So I appreciate all of you being here today, and I appreciate the opportunity for us to share this information with you. So let's advance to the next slide. And this is our Partners in Health and Wholeness team. So in case you're not already familiar, there's Reverend Dr. Arlisha Simmons. She's our East Regional Associate Director. Reverend Carolee Hall, who's our West Regional Associate Director. Myself, and then Meredith Rawls is our newest team member, and she works in the central part of the state. And so, who we are, just in case you don't know, if you're new with us today, we are an initiative of the North Carolina Council of Churches, the PHW, or the Partners in Health and Wholeness Initiative is. And the North Carolina Council of Churches was actually founded in 1935, so we're going to be celebrating our 90th anniversary today, which we're not today, I'm sorry, this year in November, which we're really excited about. So, look for information on that forthcoming. And we, as a initiative, we prioritize the intersections of faith, health, and justice. We connect, empower, mobilize, and partner with congregations across the state and any faith community across the state to seek holistic health and well-being, as well as within their surrounding communities. And so, here are some upcoming webinars in case you don't already have them on your calendar. This is part of our Abundant Life webinar series. And you can also find this information on our website, but just in case you don't have it, we'll be having this series of webinars throughout the spring. And then we're also going to be having some in-person faith and mental health summits. We're having 3 across the state this winter and spring. And the first one is the end of this month on the 27th in Asheville. Then we're going to be having one in March in Sanford. And then way in the east in Greenville on April 3rd. So we would love for you to come and be a part of those. It's a 10 to 3 day. So each one will also be very different. So we welcome you to participate in one or as many of them as you would like. And you can register for those on our website as well. And so without further ado, I would like to introduce our partnering presenters today that we're very happy to have with us. They are former colleagues of mine. And we have Karina Martinez Gonzalez. She's an MPH, and she's the Director of Epidemiology, Communicable Disease and Preparedness, as well as Lindsay Sullivan, MSW, and she's a health strategist. And they are both with App Healthcare, which is also known as Appalachian District Health Department, that covers Watauga, Ashe, and Allegheny counties up in our northwest part of the state in the mountain region up there. So I will go ahead and hand it over to them. Thank you both so much for being here today with us.
Thanks, Donna. Let me see if I can get our screen set up here. Okay. Are y'all able to see my slides? Okay, thank you. All right, Karina, I think Donna did such a good job introducing us. I'm not sure if you have anything to add, but feel free to take it from here.
Okay. The only thing that I have to add is part of the reason why Lindsay and I are here to share is that both of our roles interact with the community health assessment for our 3 counties, Allegheny, Ashe, and Watauga. And so over the past year and a half, 2 years, I can't remember. Lindsay and I and a couple others have been working together to put together the 2024 community health assessment. And then beyond that, we also use the data from the community health assessment in our day-to-day jobs. Okay, can you go to the next slide? Thank you. Okay, so first of all, we sometimes call things by abbreviations in public health, and by sometimes I mean very frequently. So if there's any clarification, please feel free to ask. But CHA or CHA is commonly used to refer to community health assessments, and then CHIPS for community health improvement plans. And then in the years in between doing a community health assessment, there are also SOCHs, so state of the county health reports, which I'll be referring to as well, just for y'all's awareness if you come across those acronyms at any point. So the community health assessment overall is a data-driven process that works to assess a community health's needs. And it is conducted often by a coalition, a group of people, that is facilitated either by the health department or by the hospital. And for Lindsay's and my side of things, from the health department perspective, we conduct ours every 4 years. The hospital requirements are for the health assessment to be conducted every 3 years. And so sometimes counties will work together with their hospital and be on that 3-year cycle. And then other times they'll work more independently and be on a 4-year cycle. So that's just some general knowledge as to if you're what most recent version it is that you're looking for. And then on the years in between there is when the state of the county health report happens, which is essentially an update on all of the information that is in the community health assessment. So if there's been any big changes in the data about the state of health in the area, and then it's also an update on the community health improvement plans. Okay, so once to explain how the community health improvement plans and the community health assessment interact, the process for doing the community health assessment, including the CHIPS, is really normally a 1 to 2 year process where you start by looking at the state of the county with all the secondary data. And then you also work on collecting primary data to fill any of those gaps. So primary data is things like focus groups, surveys, anything that's directly getting information yourself versus looking at what data is out there, like the census. And so once you have the CHA built, it gives you a picture of what are the priorities of the community. That's often one of the things that is collected in the primary data. What are the biggest needs? Where are the gaps in health? And all of those things. And those inform the CHIPS, so the community health improvement plans, which work on addressing those main priority areas that are identified in the community health assessment. And so how I mentioned that the CHA is done by the health department, but often in collaboration with a council or a group or a committee, that's the same for the CHIP. So after the CHA is completed, then those community groups of partners will work together to identify what the improvement plans should be and to help put those together and then to think about what the action should be at the low level versus what the goal should be at the high level and all of that. The key goal really of having a community health assessment is to understand how all of the various aspects of life, so things like housing, transportation, education, demographics, and then income, all those kinds of things, how they impact health, and then like the really specific health outcomes that you can look at too. So things like morbidity and mortality. So looking at death rates, the rates of chronic illnesses and chronic diseases, and all of those things that are more traditionally under the perspective of health. But since the community health assessment includes that really broad level of income, housing, education, all of those things, which we call the social determinants of health, it's a really good source to look at for data on kind of a snapshot of what your community looks like. in regard to those areas. And of course, there are caveats, as there always are, which we'll get into in a second. But it's a really phenomenal tool and is something that is updated, and that that on a county level that staff are interacting with and working from the information that's in the document. Of course, again, there's caveats, but it is a really helpful process. And one of the things that I often think is the most impactful is when you have primary data that is collected locally. So things like the Youth Risk Behavioral Survey, which I'll get into in a second, and the primary data collection process like focus groups or surveys and all of that. Having actual voices of the community members reflected in the process is really impactful in not just thinking about what the broad level data says of like blank percentage of our population is unhoused, but thinking about the actual community members and what their priorities are for the state of health in the area. And interestingly, I think that's one of the things that we often see brings mental health to the top of the focus area, is that communities are invested in mental health. And so I feel like partially it's that factor of the primary data of what people are invested in that brings that topic to the forefront. Okay, so let's see. In looking at the data in the community health assessment, there's a lot of different uses for what is there. So as I mentioned, there's the social determinants of health data. So things like education, housing, income, socioeconomic status, all of that. There's also demographic information. So knowing what your county looks like and is made up of can be helpful. So if you have a really high number of youth in your county as compared to the state, that can be helpful in showing the importance of doing upstream work to help mental health access for youth, right? If there's a higher number of youth, and then you also see that there's higher numbers of poor mental health outcomes and such. Those kinds of things, looking at both the demographics and the makeup of the county in combination with some of the health topics, can be really impactful in driving those points home in grant applications and working to get buy-in from partners and informing the work that you do. And then the other thing that I think can be helpful in looking at a community health assessment is to understand not just what drivers of health are overall, but what are the locally relevant and important topics. So for example, in our communities, one of the things that was highlighted to put on the opinion survey that we do, so the primary data we collected, was family and social support. So that's a topic area that's not always included, but has been something that's been important to our communities. And so that is one of the areas where we ask questions and gathering that primary data. And then it was elevated as a priority area in one of our counties this past cycle as well. And that very much differs based on the county. There's this saying in public health of when you've seen one local health department, you've seen one local health department. So every county is very distinct and has their own systems, has their own processes, and it's kind of the same for community health assessments. So there's not one template that says all of what will be included and all of what is not within the purview of a community health assessment. And so that's to say, they really are unique in that aspect of things. Some common things that can be included when talking about a health topic area, like what I mentioned of housing, education, socioeconomic status, morbidity, mortality, all those things, is an explanation of what the topic is, how that topic relates to health, especially if it's one of those things like education or housing, whereas it might not be as clear for some. And then disparities that show up in the data. So if your county as a whole has a mental health access to care rate that's one thing for people who have private insurance versus another thing for folks who have Medicaid or Medicare versus those who are uninsured, right? That's a disparity that is important in understanding the differences in how individuals interact with health and healthcare systems. So those things are often illustrated within the community health assessment. And one of the other outcomes that can come out of the community health assessment, other than the improvement plans, is that in general, it can be used to help prioritize health needs and inform decision making. And that happens at a high level. But looking at looking at the data and then making sure that data is used in coming up with various different actions is really helpful in making sure that you're using your resources as best as you can and thinking through, oh, this is the group that is most impacted. And doing some of that intentional thought work to figure out how and where to have the most impact. So let's see, for improvement plans, those are really the action steps, and those after the health assessment is done are what happens in the interim years until the next community health assessment is completed, and those priorities might change. So those are often things that you could get involved with by reaching out to your health department or reaching out to the community coalition if you know who it is who is working on these things. And then for updates on what's happening there, looking at the state of the county health report can give you some information just on what the improvement plans are about and what the topics are and such. Okay, can you go to the next slide, Lindsay? Okay, so knowing where to find the community health assessment and the community health improvement plans is generally pretty easy with a quick Google search. So I will actually go ahead and walk us through that process, but local health department websites are a good place to look. State websites can be resources. And then you can also find folks who have referenced the community health assessment. I find it often best to, instead of using somebody who has referenced the community health assessment itself, to actually then go and find the community health assessment to look at and to cite. But I can go ahead and share my screen here and we can do this process together. Okay. Can you guys see my Google window? Yeah, okay, thanks. Okay, so I looked in the chat and I think I noticed that somebody is from Cary, and then let's see. And then I see Franklin County mentioned. Okay, so Cary is in Wake County. So what I'll Google is Wake County, North Carolina, Community Health Assessment. And when I do that, oops, I have to move the chat box. Sorry, give me 1 second. Okay, so the first thing that comes up here is Wake County government. And when you open it, it comes up and it talks about, it explains what the community health assessment is. And then you can see that coalition group that I was talking about. In Wake, it looks like it's called Live Well Wake. And yeah, their most recent community health assessment, it looks like, was done in 2022. So 2025, I think, will be the next one. If you see here, it looks like they had been on a 4-year cycle from 2006 to 2010, and then maybe moved to work with their hospitals to be on a 3-year cycle. So anyways, if you expand this, you can see the full report, which if you click on, will open up and check the site connection. And then here we go. The Wake County Community Health Needs Assessment. And I love their layout. This is very nice. So the table of contents can be a good place to look to kind of get an overview of what might be included here that you can look at and reference. But yeah, that's the best tried and true strategy is to look for the county name specifically rather than the city, but then to look up community health assessment since some folks have their own, some places have their health department information as a part of their county website. Other people have their own websites. So anyways, that's the easiest method that I found. And then let's see, I think the other one I'd seen was Franklin County NC Community Health Assessment. Okay. Franklin County Community Health Assessment. Okay, here we go. And right there is a picture of it. And then down here you can see they have more information on their website than I think some others do. So you can actually see their improvement plans. And then you can see 2021 Community Health Needs Assessment. And then scorecard. So this is the state of the county health report. So this is where you can see the what has happened since the community health assessment. So any updates in the data, but also updates in what has happened in addressing it. So their priority areas are exercise, nutrition, and weight, heart disease, health outcome disparities, and communities of color. And okay, so their improvement plans are in scorecard, which is also where you can see the state of the county health report, which is really just the updates. So you can click on these things and expand them, and it'll give you a description of what's going on. And then let's see, here it shows 2019 data for access to exercise opportunities. And then over here, you can look at the full community health assessment and find information here. So as you can see, they all look different. Ours looks different than both of these. The pages are landscape, but they're all great resources, regardless of how your county conducts them and what layout is used and all of that stuff. Okay, and then Lindsay, do you want to put the presentation back up again? Thank you. Okay, and can you go to the next slide? Thank you. Okay, so as I mentioned, caveats. There are challenges that frequently come up with data and with some of the information that is in community health assessments. So one of those things is delays. And I'm sure that's something that everyone has run into. So various different types of data are published at different points in time. And when they're published is often later than when it's collected, right? Or when it reflects. And then there's often a delay from there to having it be reflected in the community health assessment. So for example, I mentioned that Lindsay and I have been working ours for a year and a half. So what that means is that in that period, there were of course different data at the beginning of that year and a half as there were at the end of it. So that can impact if you're seeing what the most recent data is. And there can be discrepancies. So one of the things that I have found to be very helpful is to look at what data is in the community health assessment, but to also look at where it comes from. So for example, if you see that there's a statistic that is from the census and you see the data are from the 2022 American Communities Survey, if you go and look for that piece of data online, you can often find like the more recent years since then, if there have been updates, and just finding the most up-to-date data. And working backwards like that is, I think, a good tool to counteract that. But there are some things that are just going to inherently have a longer delay in when they'll be published. So if you think about, for example, opioid overdose deaths, things like that, where it takes a while to do an autopsy and to confirm what the cause of death is, and then to get the death information updated in the state system, causes for that kind of information to be behind quite substantially. Um, versus like if you're looking at the something that's more like how many people participated in this program, right? Once the program is over, you can get that information pretty immediately. So those are two opposite ends of the spectrums in terms of examples. But it's important just to think about that. And then also, um, if you are submitting a grant or something that's talking about those things, often the folks who you're submitting the grant to will be familiar with the delays that exist in the data, um, since that's their area of knowledge and expertise as well. Um, in thinking about how data is collected and reported, one thing that can sometimes happen is somebody will paraphrase what is written in a community health assessment, in an article, in any one source, and then they'll get a different conclusion from the information that is highlighted. And so then if you're looking at the information that has been paraphrased, if it's not the same as what's in the article, but you cite the article, that can cause a difference in what you are saying is the statistic that you're looking at versus what is the actual statistic in the paper, or the assessment or whatever it may be that you're looking at. And then let's see. Let me just check my notes to make sure I've said everything I wanted to here. Oh, there can also be one of the things that we see a lot is also different definitions of things. So, and small words that make big differences in terms of what something is saying that can, excuse me, make it look like there is a discrepancy. So, for example, if you're looking at measures of who spends 30% or more on housing in a community, and you look at how community is defined, sometimes that is a town, sometimes that's the county. Normally for housing data, it will be the county or a zip code or something. But paying attention to those little details, and then also like what constitutes income, right? Is it individual income, or is it the whole household income? And is it before tax or after tax? All those things can make little differences if you're seeing data that's coming from one place that says one thing and then data from another place that says another thing. Another thing that can be a little bit, that can cause some confusion, is when you're seeing a year that's being cited, often the year that's being cited is the year the data is published, not the year that the data reflects. So if you see something that says data from 2022 show that the housing insecurity has increased by 5% in Watauga County, for example, then that data is what happened in 2022, which may have then been published in 2024, versus if you're seeing something that says data published in 2024, that's again, 2024 doesn't mean that's when it was collected, more so that that's when it was put online for others to access, and that's when the data became broadly available. So both pieces of information are important, and are helpful in, citing your own information, but can cause some confusion, especially because between sources. So a lot of folks reference the census website. So you'll see that on various different folks who provide kind of summary level data about a community. And that's one of the things that can get a little bit lost in translation, is what specifically the year that is placed is referring to, whether that's the year that the data is published or whether that's the year that the data reflects. So again, the way to kind of combat this is going back and looking at the source that's being referenced. One thing that can also happen is when there are large scale events like COVID-19 or Hurricane Helene, they can very much change the landscape, and that will take a while for those kinds of the data changes to be shown in the community and for those to be reflected there. Or sorry, not in the community, but in the data themselves. The community sees the changes first, and then the data comes after that. And so those are just caveats. One really phenomenal source of information is the Youth Risk Behavior Survey. So that's something that happens at the local level and provides really great information on youth behaviors. It's conducted in schools and it can be a really helpful thing to look at trends, so changes in the data over time. And also to get a grasp of what youth are experiencing. So that's a phenomenal resource that I highly recommend. Next slide.
Okay, thanks, Karina. So we've talked a little bit about data and how to access it. Let's talk about the value of faith-based partnerships. So I'll start with trusted messengers. Faith leaders are deeply trusted by their communities, which make them valuable partners in public health efforts. Community reach, faith-based organizations often have strong networks. They can engage different populations, including those who may not regularly interact with health services. Shared mission, public health and faith communities both prioritize well-being of individuals and families, so that makes collaboration natural and effective. Vulnerable populations. Faith-based groups often serve vulnerable populations, so helping to bridge gaps in healthcare access, information, providing resources. Local health departments can help equip you with that information to help navigate conversations. And then crisis and emergency support. Local health departments rely on faith organizations during public health crises. So we've seen this with pandemics, natural disasters, just helping to provide messaging, support services, resources. This is obviously big for us up here in the aftermath of Hurricane Helene. Our partnerships with our local churches has been essential in our long-term recovery from the hurricane. Ways to get involved. What are some ways to get involved with your local health department? We've talked a little bit about this, but participating in the CHOT and CHIP discussions. So attending public meetings or focus groups hosted by your health department. Sharing insights on community needs based on lived experiences and faith-based outreach. What are you seeing that you can help share with your local health department? Advocating for priority areas that align with your community's concerns. So maybe it's mental health or food insecurity, or maybe chronic disease prevention. Helping disseminate surveys, so encouraging congregants to complete the child-related surveys to ensure representation of those folks. Distributing paper or online surveys through faith networks or a newsletter, social media, bulletins, however you get information out. Offering to host survey stations at faith gatherings, anywhere that would make participation in those surveys more accessible. And then hosting health events at faith centers. So partnering to organize health fairs or screenings or vaccine clinics. You can invite your local health professionals for educational workshops. Using faith spaces as safe, familiar locations for health discussions or mental health support groups or fitness programs. Basically, health departments need faith-based partners to build healthier communities. So your involvement definitely can help ensure that public health efforts are community-driven and impactful. So let's talk a little bit about faith-based partnerships and what that can look like, especially when it comes to acting on what the local data is telling us. So here's some ideas or examples. Congregational health ministries. Many faith-based organizations have health ministries that provide screenings, health education, chronic disease support, that type of thing. I'm sure you all have seen this in action. Vaccine and health clinics. Partnering with health departments and hospitals during COVID-19. This was a big thing, especially in our area, helping to provide vaccine clinics in trusted settings, especially if there's central location for community members. Mental health and crisis response. Some congregations have trained clergy or lay leaders that can offer mental health first aid, grief support, and substance use recovery programs, community gardens, and nutrition programs. Churches have started gardens to provide fresh produce for food insecure families. So these are all examples of faith-based partnerships, and I'm sure that you all have seen more. I think it's helpful just to make the connection that a lot of this stuff is stuff that is likely already being done just out of caring for your community, but seeing that connection of health departments can really help in those efforts. So it's not necessarily starting something new. It could just be seeing how we can work together moving forward on programs that are already underway. So getting started, you can start by looking up your CHA or your CHIP. So using our walkthrough from earlier as an example, try locating your county's reports and action plans if you haven't already. Look around and see if you can locate what top health concerns have been identified for your county. What priority areas for improvement do you see? Is it mental health, chronic disease, food insecurity? And then what initiatives or gaps in services have been identified, and those reports are on those websites. Understanding your community's health needs so that you can align your efforts with priorities that you see identified. Connecting with your local health department, just reach out. Contact your health department's community health or outreach team. They're likely looking for partners if they're not already partnering with you to help implement health initiatives. Join discussions, ask about opportunities to participate in the CHA and the CHIP meetings, focus groups, advisory boards, partner on programs. Health departments often need trusted community spaces for outreach and education and services. So faith communities can help fill this role. Identify community needs your faith community can support. So assess your congregation's strengths. What existing ministries or outreach efforts align with public health needs? Maybe you see in the report something that you're already doing. Help make that connection if you're able to talk to someone at your health department. Engage your members. Ask what health challenges they see in the community. Their insights could guide your involvement. And then start small and build. Consider simple ways to engage. So sharing health resources or hosting a survey station if it's time for surveying, or inviting a speaker from the health department. It's okay if ideas don't pop up straight away. Just taking the initial steps, learning about the CHA and the CHIP and connecting can lead to a really meaningful partnership. And so get connected and just see where it goes. All righty. I'm gonna stop sharing and see any questions for us.
You all are welcome to come off mute and ask questions or put your questions in the chat, whichever is easiest. If you have any questions for Lindsay and Karina, or if you have questions for our Partners in Health and Wholeness team. Okay, and we can always connect you all later, and y'all will be receiving the recording of this webinar today. And thank you so much, Karina and Lindsay, for sharing all this wonderful, valuable information with our faith leaders. It's really, I think, important for us to know where to get this community data and the valued relationship between faith communities and public health. So thank you all so much. Thank you for everyone for being on, and thank you again, Karina and Lindsay. And if no one has questions, we will let you go early today. And I don't see any questions in the chat. And oh, yes.
We just want to remind people that we will be sharing the survey link. So if you could please complete that, we would greatly appreciate it.
Yes, thank you so much, Arlisha. So, have we put that in the chat? We're going to put that in the chat. So, it's going to be a post survey link, and we'll send that out later as well. So, the link is in the chat currently. If you'll click on that, and you can complete it later or whenever you have a chance. And like I said, we'll send it out with the recording as well. Does anyone else on the PHW team have anything to add? Okay. And, or Jennifer, do you have anything? Our executive director, Jennifer Copeland, is on with us today as well. Okay. Okay, well, thank you all so much. We really appreciate y'all spending an hour with us, and have a great rest of your day.